Thank you very much for giving us the opportunity to present our case here today. Our case, we have no conflict of interest. Our case will be on a 45-year-old female who was admitted to hospital because of pain in the upper abdomen. The pain started 3 weeks before. It was progressive. It was typically postprandial. And at the time of admission, she could hardly eat anymore because after each meal she had enormous upper abdominal pain. What the local hospital first did was a gastroscopy, which was completely normal, and also an abdominal ultrasound, which showed no abnormalities. And then they decided to do a CT scan, and I'm showing you the images here. And as you can see here, where the arrow is, that's the celiac trunk. There is a stenosis in the origin of the celiac trunk of about 60 to 80%. Further, this is where the superior mesenteric artery should start, but as you can see, it's completely gone. So the CT is showing 80% stenosis of the celiac trunk, and the superior mesenteric artery is totally occluded. What they did is they performed a balloon angioplasty, as you can see here in the figure, and put in a stent in the celiac trunk. And that resulted in a complete resolution of the complaints of the patient. But unfortunately, the procedure was complicated by the section of the brachial artery. But in the end, that recovered quite well. Our first question to the audience is, what is your differential diagnosis on the cause of these vascular abnormalities? And what further analysis would you suggest to do?
Okay, so you can ask for the microphones and take part, or we can allow. Oh, there is a coming to the microphone is a brave first discussant. Please introduce yourself.
Ehud Grossman from Israel, and my question is whether it's maybe type of vasculitis, and we need to see if you had some laboratory evaluation of the possibility of vasculitis.
Yeah, I think that's an excellent suggestion. I will show you in a minute, but the CRP and other inflammatory markers were completely normal. So there were no signs of inflammation by the time of admission.
Could we ask presenter to be a little closer to the microphone?
Yes.
The acoustics in this room is not perfect.
Any other suggestions except for vasculitis?
Michael Burstein, Jerusalem. I would like to ask whether this woman had lost a lot of weight preceding to the symptoms. Sometimes when there is a loss of fat, there is an angulation of the superior of the celiac axis, and this may appear as this angulation may appear as stenosis and cause abdominal angina. Yeah. So is there a history of substantial weight loss preceding the symptom?
Yeah, excellent suggestion, I think. It started only 3 weeks before the hospital admission, and then the weight was stable. Only the last week she lost 2 or 3 kilograms. And the disease you're suggesting is the Wilkie syndrome or the superior mesenteric artery syndrome. And that only affects an occlusion of the duodenum, so it's not exactly the vessel itself. So I don't think that's the case here.
Wilco Spiering, Utrecht, the Netherlands. Were there any clues of atherosclerosis? Had she a smoking history?
Very good question. She had a smoking history for a few years. There was the CT of the abdomen revealed only 2 little spots in the distal aorta of calcifications, but not in the vessels that were affected.
Professor Rossi.
Thank you. My question is on the same line. Did the patient have familial hypercholesterolemia or severe hyperhomocystinemia? Because the differential diagnosis is between atherosclerosis and fibromuscular dysplasia. So
Yes, again, an excellent question, I think. The lipid levels were completely normal, and their homocysteine level as well, and their family history was not prone for a familiar atherosclerotic problem. So that was not the case.
Okay, yeah. I think we want to progress with the case, if you may.
So what they did in an analysis in the local hospital, they looked at the CT scan, and as we mentioned before, there were no signs of calcification or thrombosis in the affected arteries, just 2 little spots of calcification in the distal aorta. They did a 24-hour Holter monitoring and cardiac ultrasound, which revealed no abnormalities. And the laboratory tests revealed normal lipid and glucose levels. There were no coagulation abnormalities. They did quite some tests, including lupus anticoagulant and protein C and S levels, all normal, and also the inflammatory markers were normal. And that was the point that she was referred to us in the university hospital. So my question to you is, what would you do next? What would be the next step to find the diagnosis or the underlying disease that is causing these vascular abnormalities?
Professor Rossi has another word.
Well, to get abdominal angina, you need to have occlusion of 2 out of the 3 vessels, and 1 with stenosis. You can tell us about the inferior mesenteric artery. Please do.
It was completely normal. It's completely open.
Okay, so I have a different question. We are at the hypertension meeting, and we haven't heard anything about the blood pressure of this patient. Could we hear a little more about her blood pressure, please?
Very good. Because when she came in our outpatient clinic, we started doing additional history taking. And then the patient mentioned that when she was 36, she had a hypertensive crisis with blood pressure up to 240 millimeters of mercury. And she mentioned that 1 year earlier, her blood pressure was fully normal. She had a checkup at her general practitioner. It was normal. So in 1 year, it increased from normal to 240 millimeters of mercury. At the time of admission, this was well controlled with 3 antihypertensive drugs. What I also asked the patient is whether she had tinnitus, and she told me that sometimes she had episodes that she heard it, sometimes in the left ear, sometimes in the right ear, sometimes in both ears. And I always ask patients to tell me what it sounds like, and she says, I'll hear this shoo, 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 shoo. So a swooshing sound on her heartbeat. Further, she was in another hospital 1 year earlier because of her exertional chest pain. And the cardiologist did an exercise test. And during the exercise test, she had some ST segment elevations. And therefore, the cardiologist decided to do a coronary angiography. And these are the results of the angiography. And as you can see, there are no real stenosis in the coronary arteries. But what they did note was that in the distal coronary arteries, there's quite some winding of the coronary arteries, which is called tortuosity. And that was an interesting finding, I thought. They didn't do anything, changed her medication or didn't do an intervention.
Was that noted at the time, or is that a retrospective finding once you knew the diagnosis that this patient...
Sorry, I didn't get the question.
Was that tortuosity of the coronary arteries noted at the time?
The cardiologist wrote down that he thought it was a little strange aspect of the distal coronary arteries. Didn't use the term tortuosity, but he noticed that it was not normal.
Okay.
So to summarize, we have a patient with visceral artery abnormalities with a stenosis of the celiac trunk, occlusion of the superior mesenteric artery, and additional history taking revealed rapid onset hypertension, pulsatile tinnitus, and coronary tortuosity. So again, the question for the audience, what is your differential diagnosis now, and what would you do next?
Okay, so we have 2 people at the microphone. Go ahead.
So it looks like it's a disease that affects at multiple levels. So I think you would either need a CT angiogram or an MRA of all the blood vessels in the body, especially the medium-sized arteries.
excellent suggestion, I think.
Mohamed Barigou from Paris. Given the young age of the patients, first thing, the fact that she had multiple vessel involvement, and the rapid onset of hypertension and the grade 3 hypertension that is really important, we should seek for every secondary cause of hypertension, particularly because there is vessel involvement. Take a look to renal arteries, if there is the same involvement. And considering the abnormalities that were seen in her coronary arteries, couldn't we seek for Kawasaki disease that could give some coronary arteries in the same time? That is a systemic disorder, but it's very rare in some conditions. That's my proposition.
So we now have Professor Perso, a world specialist on fibromuscular dysplasia. I think he'll tell us something we want to hear.
Well, when we look at the additional history taking now, each finding separately is not specific, but when we look at all the findings, it's extremely suggestive for a widespread fibromuscular dysplasia. We have the hypertension. The Americans have learned us that pulsatile tinnitus, especially swooshing, as you mentioned, is quite suggestive of carotid fibromuscular dysplasia. And then coronary tortuosity is found in patients with spontaneous coronary artery dissection, which is strongly linked with FMD. So I would say the probability of fibromuscular dysplasia is very high now.
I think that's an excellent comment. What I show you here is the most common presenting symptoms of fibromuscular dysplasia. This is a table from the US registry of patients with fibromuscular dysplasia. And if we look at this closely and put our own patient in here, then you see that the patient suffers from hypertension. She has a pulsatile tinnitus and chest pain upon exercise, and also the postprandial abdominal pain, which are all clues that may lead to the diagnosis of fibromuscular dysplasia. As you indeed mentioned, coronary tortuosity, there might be an association with FMD. As you can see, the most common coronary artery abnormality that is associated with FMD is the spontaneous coronary artery dissection, SCAD. If you perform a CT scan of other vessels in patients with a SCAD, you find a string of beds in approximately 60 to 80% of the patients. So the vast majority of patients with a coronary artery dissection has FMD. But there are several other coronary artery abnormalities associated with FMD. As you can see here in the figure, the smooth narrowing or the intramural hematoma, or, as in this case, the tortuosity. If you look at patients with the SCAD, then almost all of those patients have coronary tortuosity. A while ago, we questioned ourselves whether that might be a clue for FMD as well. So we looked at a few patients, just 5 of them who had coronary artery tortuosity without a SCAD, and looked for them whether they had FMD. And indeed, we looked at these 5 patients, and they all had FMD. So I know it's a very small series, but I think there has to be an association between coronary artery tortuosity and FMD. So for that reason, we thought, would there be any other localizations of FMD? And could we find, for example, a typical string of beds? What we first did is we revised the CT scan that was already made in the other hospital. And the right renal artery appears fully normal, but in the left renal artery, there appears to be a stenosis at the origin of the left renal artery. It's perhaps a bit difficult to see, but this is where the problem is. And therefore, we decided to do renal angiography with a catheter, and my colleague, Professor Kroon, will discuss that with you.
As is the case in the clinic, I always are present at the renal angiography, so that's why I discuss it with you. And this is the angio we made, and I show you this picture. This is the midstream measurement, and here you have the right renal artery with abnormalities, and here is the left renal artery with another abnormality. And we have a selective view of the right renal artery, again with the same abnormalities as you see on this picture. And again here there is the hint of the stenosis on the left renal artery. So does this change your diagnosis, or does this change your ideas with respect to what the diagnosis should be?
Great, we have two people coming to the microphone, please.
Wilco Spiering, Utrecht, the Netherlands. No, it does not. I think it's typical for FMD, but what is really striking that on the right renal artery we see a differential beats, and on the left you see a unifocal stenosis.
Yes, indeed. Yeah, I completely agree, and that's well, should rethink your diagnosis, because we have never seen a picture of the string of beds in one artery and unifocal stenosis on the other artery. We have seen unifocal disease on both arteries or on several sites in one patient, but not this combination. So does that change your...
Well, actually, it was my question to you. I have never seen such a case.
Okay. Well, then we agree.
I have a question and a comment. First, about the focal lesion. How can you rule out that it's not isolated atherosclerotic lesion, which is quite proximal here?
Yeah, well, that is indeed what we were afraid of, but we have been looking in detail in this patient to see whether there is atherosclerosis. And as we said before, there is no signs of atherosclerosis anywhere, only small calcifications in the distal, very distal aorta, and whatsoever no other abnormalities in the aorta. And you know, atherosclerotic renal artery stenosis is an aortic disease, and there is no signs of that.
The second point is we reported recently with Dr. Jean-Philippe Langelet a family with 3 sisters. Mm-hmm. All of 3 have FMD, 2 have clear multifocal renal FMD, and 1 had a focal stenosis, and on the other side, mild irregularities compatible with multifocal FMD. So I think it's rare, but it might exist. Okay. And I also remember of a family shown by Xavier Jeanmaître with in one SIB multifocal FMD and the other focal FMD. Is quite different because it's not the same patient, but still it suggests it can be the same disease.
Yeah. Thank you for your comment. I think I agree.
Why the renal arteries were not looked at when she was stented on the celiac trunk? Because in a patient with hypertension, I would do really an examination of all the of all the arteries, maybe throughout the body, not only of the celiac trunk of the superior mesenteric artery.
I completely agree with your comment, because they should have done that as they put a stent in the celiac trunk, but they didn't, because they didn't have, that was in the other hospital, so they didn't have the hint that this was fibromuscular dysplasia, and you should look into the renal arteries.
Just in a similar vein, did she have a renal bruit, which might have given an indication earlier that... Did she have a renal bruit?
No. I'm not sure. You looked into the patient more carefully, Dan?
I don't think so, no.
No, she didn't have. She didn't have a bruit.
Your center is an expert center on flow measurements of renal artery. Did you do these measurements in this patient?
We did. Well, I don't think we did a xenon. No, sorry. in this patient, we didn't do the flow measurement, and that's due to shortage of xenon at that time. Sorry. Otherwise, of course, I would have shown you this data.
Could I ask a naive question? Clearly, in clinical practice, at this stage, we would say, this is FMD, it could be 1 or 2 types, but this is a young woman, we proceed to angioplasty because we want to treat this condition.
Well,
so does it matter all that much whether one kidney is slightly different than the other? The only worry would be that one is atherosclerotic and the other is FMD. But if you could, with all logical argument, clinical argument, exclude atherosclerosis, for me, you just proceed with action.
Well, there may be, you're completely right, but there may be a difference. If it's FMD, you only do the balloon dilatation, and if it's atherosclerosis, you would prefer to put a stent on that left renal artery. So there may be a difference, but indeed, the discussion is a bit academic. So, well, our diagnosis. We think this is multifocal FMD of the right renal artery, and we think that there is quite some evidence that both in the celiac trunk and the left renal artery we had unifocal FMD. And of course, well, we discussed as to whether this could be atherosclerosis, but there were only small calcifications in the distal aorta and not at the side of the celiac trunk or the left renal artery. And probably the occlusion of the superior mesenteric artery, which we seem to forget, may be a severe stenosis or even a dissection, which also fits into the diagnosis FMD. So, well, I hope you agree, and I think that with respect to the discussion we had, that you do. So, then there is the issue that we have 2 subtypes of one disease or 2 different diseases. And there is quite some discussion in the literature with that respect. There is also difference between unifocal and multifocal disease. The angiographic appearance, this is the string of Bethe, and this is the typical unifocal stenosis. But there is also histopathological difference. In the here you have medial disease, which is almost always found in patients with the multifocal disease with the string of Bethe. And this is the abnormality of the intima, which is almost always found in the focal stenosis. So, and there is also a difference that here you see histopathologically also the severe stenosis, and this is, as we've shown in our studies also, there is not that much of a stenosis, and they seem to appear like essential hypertensive patients. And then there is another issue, the clinical characteristics between unifocal and multifocal disease are different. In multifocal disease, patients have a diagnosis of hypertension at much younger ages, and the diagnosis of familial FMD is also at younger ages, and they have much higher blood pressure, and also their renal function is sometimes deteriorated, and some of these patients with unifocal disease present with asymmetric kidneys, with an atrophic kidney already at young age. So, and then we've shown ourselves, but I won't elude that now further, that there is also a significant difference in renin secretion between the unifocal and the multifocal FMD. So, in our minds, it is 2 different diseases, and that presents in one patient.
Sorry, Professor Rossi has comment or question.
Yeah, thanks. Going back to Professor Dominicak's point, is this important to say it's atherosclerosis of fibromuscular dysplasia? My experience is that with patients with long-standing hypertension, starting at a very early age and never screen for secondary forms. You can start with a fibromuscular dysplasia, and after 30 years, 40 years, when they show up, they have atherosclerotic lesions,
Sure.
be it because of the chronic activation of the renin-angiotensin system or because of age or exposure to other things. But at that stage, they might present with severe resistant hypertension. So I think, if I may say, Anna, with the polypill approach we will see many more of these cases in the future.
Well, I completely agree with this comment. This is something we've seen already. We have patients of 65 years old who present with fibromuscular dysplasia and atherosclerotic renal artery stenosis. So it's a combination, and that's due to, not diagnosing the fibromuscular dysplasia at early ages. But I think we have to move as to whether we should do something with this patient, and that may be a point of discussion. Are we going to balloon angioplasty in this patient or not?
Well, I think it's.
Could you tell us who you are?
Yoni Sharabi from Tel HaShomer. I think it is critical because a few years ago, I think it was 2010, at Hypertension, they published what is the outcome in FMD when you do angioplasty. And apparently age is a major factor because you want to cure patients with FMD. So at a certain age, the likelihood that she will be cured, not need medication and not repeat, is critical. So at her age, if I remember well, the graph that looked at age and response to treatment in terms of long-term response, she is like about 30 to 40% chances that she will be cured from her blood pressure. So she has to decide whether it's worth the angioplasty. And the other thing, again, it goes back to what the etiology. If it's atherosclerosis, then the likelihood is even less. So it's probably FMD at her age, and the duration of the disease of her blood pressures are two important factors that you can tell your patient whether or not it's going to be for long term or not.
Okay. Well, I can agree that, and I'll await the second comment of Alexander.
Well, I think I would go for blood pressure gradient measurement in this patient because the focal lesion, we are not completely sure it is FMD, so how will it respond? And the typical string of beads is relatively mild. And also we have learned from Professor Olin that with the same string of bead aspect, you can have gradient from 0 to very high gradient. So I think you might consider it in this case, and probably this will be proposed for all patients with string of beads in the upcoming international FMD consensus. But I know there are no specific study on FMD, and we discussed this already. Yeah. But still, from a pragmatic point of view, I would do it for this patient.
Well, the discussion is then what one should take off as cutoff, because the cutoffs of the change in blood pressure between the pre-stenotic blood pressure and the post-stenotic blood pressure we have is only studied in subjects with atherosclerotic renal artery stenosis and not in FMD. So what would be the cutoff?
I agree, we don't know the specific cutoff, but if the gradient is near to 0, which is, I think, possible here, what would you do? Would you act only on the other artery, and then would you put a stent or not? The question is difficult to answer.
I'll show you the data in a moment.
Thank you.
I think that balloon angioplasty is what is being asked for. Nevertheless, and I think generally speaking, from a clinical perspective, it's a bit obscene to stick to diagnosis or to diseases to a single patient with a single entity, vascular disease. Nevertheless, it is theoretically feasible to perform intravenous ultrasound and to identify the presence of atherosclerotic plaque if you think it's critical.
Well, that we could have done. You could have done an IVUS in the, but we didn't do it. Well, we had some arguments for what we did. And one argument is this curve. We have a 45-year-old lady in which the pre-test chance of curing her hypertension would be something between 30 and 40%. Then we had a well-controlled blood pressure with 3 antihypertensive drugs. She had a blood pressure below 140. She had a normal kidney size, so no atrophic kidneys, especially on the left side. She had a normal renal function with respect to GFR and estimated or calculated creatinine clearance. And we did, Alexander, for your sake, the trans-stenotic pressure gradient. And we measured over the right side a pressure gradient of 13 millimeters mercury, and over the left side a pressure gradient of 15 millimeters of mercury, which is somewhat less than 10% of a change. So that left us with the same difficulty as we had before we did all this. Well, I decided not to do a balloon angioplasty with this information. So we decided to observe this patient, observe blood pressure and treat blood pressure as best as possible. And if there were changes going on in blood pressure level under these 3 drugs or changes in kidney function, we will go for angioplasty in this patient. But of course, this is debatable, but that was our choice.
So could I ask you, what sort of follow-up, how carefully and frequently are you going to follow up this patient? Because of course things could progress. We've all seen sometimes quite rapid progression of renal artery stenosis, whatever the etiology. So how frequently are you seeing this lady in your specialist clinic?
We see her every 3 months, and we do our the standard blood pressure measurements, and once every 6 months we have a creatinine level in this patient, and up till now everything has gone as we described here.
Okay, so any comments on this management, expert?
Just a question of terminology, really. Do you consider then by this decision that this lady has renal artery disease but does not have renal artery, but does not have renovascular hypertension?
You're completely right. She has renal artery abnormalities, but we haven't shown that she has renovascular hypertension. Sure.
Thank you. Dr. Rossi.
Can you tell me where exactly you put your catheter for the pressure measurement?
Yes, we came the farthest point we saw abnormalities. There we measured our blood pressure, and we measured our blood pressure somewhere here for the left renal artery.
Okay.
So really post-stenotic or post-string of beds.
Because I'm kind of theoretical problems with these measurements.
Me too.
For a number of reasons. This is like when you're watering your garden and you have a number of, bending of the tube. At the end, you have no water, no pressure. So yeah. I think one way around would be to measure the resistivity index within the kidney in the different poles and see if you have a decreased resistivity index, which will be an indirect evidence for the hemodynamic relevance of the stenosis. Yeah. I don't know if you agree with it, but I would do this.
You're right. We looked into the angiography, the echography of the renal arteries, and we've done a careful study some years ago in our hospital, and we saw that we didn't have valid results. So we stopped doing this because of the fact that it's very operator dependent, and So we didn't do it in this case, but if you are, well, there are case reports showing that you can do with echo and show that there is a resistive index, and that would change indeed. And with respect to the catheter measuring pressure, the catheter should be as small as possible. Otherwise it will wedge, and then you have, of course, no pressure at all. So you can make your stenosis if you want.
Okay, so we have time for one or two very quick comments and answers.
I understand that you suggest that she has essential hypertension with renal artery stenosis, which is not so accepted if you take a young lady with severe hypertension.
No, that's not what I suggest, but I do not know as to whether that could be the cause. That could be but I think she has fibromuscular dysplasia, and we will, with health for the time being, our standard care because she was well treated, but well, that is debatable, of course.
Yeah. So you didn't show us the results of renin and aldosterone in this patient.
No, I didn't show you
it's really important because
them in these patients, but I don't know them by head. Dan, do you know? Because you have been looking into these.
No, we didn't do it in this specific patient. The reason was that she was under medication with triple therapy, so we didn't do a blood sampling for renin and aldosterone.
Even though it could be suitable to do it before interpreting only imaging studies and not hormonal studies.
No, I would never advise to do blood sampling under triple therapy. The results you get, you can't interpret those data. If you want to do it, you should stop all the antihypertensive drugs or bridge them with other antihypertensive drugs such as alpha blockers or calcium antagonists to prevent interaction with those tests.
This is the guideline.
But in this case, we didn't stop the medication before. We just did this angiography.
Okay, I think very interesting case. And if I can be a prophet, I think it will get worse. And I think we will invite the team to come back to one of our clinical pathological conferences to give us a feedback 2-3 years on. So the invitation stands. Thank you very much.
Okay, bye-bye.